First topic is a controversy. So controversy is very nice to finish an afternoon of meeting. So the controversy is decay crush, the ultimate two-stent bifurcation technique. And the first will be by Nicolas Stoyanov, is against decay crush. And Dobrin to choose to be the second one. This is
his choice.
Yeah.
His choice. Okay.
I asked to be first because I'm always against, and that was the proposition for this debate. This debate was proposed by Professor Vassilev. I wanted to refuse, but he said you're always against, and you should take the thesis of Cons. And I want to say something before to start, that for the first time I used AI for my presentation, but I will show where exactly. And what about decay crush? This is incredible technique. Why it's incredible? Because it's a matter of interest since more than 16 years. The first study was published 2008, and you can see at the left part of the screen how many trials this technique was involved, and why it's so important and so interesting for the physicians, for the scientists, because this two-stent technique, bifurcation technique, provides better results compared to any other technique. Provisional stenting, the decay, Q-out, mini crush, everything. And this is really suspicious in my mind. Let's start with the data. Decay crush 1, 2008. I'll read fast, but against classical crush, better results. Decay crush 2, first try against provisional stenting. Not really successful, but successful in terms of target lesion revascularization. But in terms of MACE, no significant difference, and they continue. The group of Shaolin Chen, they continue to unprotected left main, really hot topic, and you can see easily. MACE at the first year, 6%. In the decay crush group against Q-out, 16%. Incredible. After that, start the battle in between provisional stenting, the idea of keep it simple, and decay crush, little bit more complex. We will see in a while, is it little bit or not, but incredible results. This technique provides more than 2 times better results in terms of target lesion failure at the first year, third year, and also at the 5th year. And if you, in this meta-analysis, if you see the results of decay crush compared to any other technique in the bifurcation stenting, they have incredible good results. And I realized that I'm really in bad situation, because decay crush is superior compared to any other technique. But I started to think how often I use this technique. I said last year 0. Why? Because this is Chinese miracle or not? And here is the point that I want to ask to help me. Who is using decay crush for every coronary bifurcation lesion? Please raise your hands. Nobody. But why? We have the best results. We have data, a lot of data, published trials, head-to-head with any other technique, and this technique is way better. Why we don't use it? And in my mind, here is the answer. We have only 11 simple steps to perform this this incredible technique, but only 11 when the wire recross easily, when the balloon cross easily through the strut, when we don't need to use smaller balloon to open a little bit the stratus after that to perform kissing or reopening. And sometimes it's much more complicated with a lot of steps to fail. Isn't it too complex? Probably it is. And European Bifurcation Group promotes since years provisional stenting, and they start other study. And probably you will interrupt me now and you say, we are speaking about decay crush. Why do you show us this study? Because decay crush was not performed in this study. Because this is the best that we can in Europe. In Europe, we are using more QOT and T-stenting. And this study showed that provisional stenting has better results and with cheaper and faster, and probably is a default technique for European operators. In this study were involved only operators from really dedicated bifurcation stenting operators, but this study failed to show that the systematically use of two stents. And probably in Europe we can't use two stent techniques. And I don't know what's the answer why in China they can stent with two stents with incredible results and Europe we cannot. And I searched in the literature, and of course I wanted to see the opinion of experts. And this is the really nice interview, not so long, of Manuel Pam, one of the founders with Professor Yves Levard of the European Bifurcation Group. And he opened my eyes, because there are several differences in between the two trials. And one is the patient and lesion included in these trials. In decay crush in China, they have really high risk patient with higher syntax, and the crucial thing that the sign branch length of lesion it's higher, much more higher compared to EBC main. And something that is strange in my mind, that in European trial, EBC main, we have only 0.8% of stent thrombosis rate, but the results from the decay crush is 2.5 for stent thrombosis in the provisional stenting group. And the other interesting thing is that the crossover rate is incredibly high. Almost half of the patients receive second stent in provisional group. The worst thing is operator related that Professor Pan mentioned. And it's not a matter of experience, because in the both trials were involved incredible good operator, high volume, dedicated operators. But his explanation is that Chinese group promote these techniques more than 15 years, and that's why they really want to achieve these good results. But the other part of the coin is that European Bifurcation Group promotes provisional stenting, and that's the answer why this study has another results. Is that true? I don't know, but this is the explanation of Professor Pan, and he proposed a little bit different way to see the Medina classification. S is short, L is long. And to make such story short, probably only exception when we should use systematically second stent in when we have a longer, more than 10 millimeters lesion in the side branch. Something out of Europe and Asia, this is trial conducted in Turkey, its road trial and compared decay crush and decay quad. And these really high volume operators, more than 5,000 PCIs in this center, showed that decay QLOT is better compared to decay crush in all of these maze. And they also failed to show that the decay crush is better compared to other techniques. And here is the point of my AI experience. I decided to search in Google, and Google AI showed for a Chinese miracle, because decay crush in my mind is Chinese miracle. And Google AI showed me this result that Chinese economic miracle, that's a different thing, but in my mind we can compare, cannot be cloned in the other region, because it's the environment is different. But we have an incredible scientist and lover of Asian culture that can show us how to translate and clone this technique and this incredible experience of decay crush in our daily practice. And this is created by ChatGPT. This is my second time. Thank you.
It's true that I'm a big fan of Asian culture. I've been there many times. I was doing their cases in China and Vietnam, so decay crush. First of all, I would like to start with why we need two stents. There are several reasons. One of the most important reasons is that when we have to manage the bifurcation anatomy, we have to have a clear image about the bifurcation. And that means that we have to have a clear image about where the carina is located and what is the relation between the ostium of the side branch and ostium of the distal main branch. The problem with the regular angiography is that for most of the bifurcation, this angiographically is impossible. And if we need a second stent, for bifurcation, there is a huge problem with another techniques, and practically we have only two techniques at the moment. We can ensure you, if you don't see clearly carina region and the very ostium of the side branch, the true ostium of the side branch for the moment, and these are QOT technique and crush technique. Because these are techniques which ensure that if you need to stent the side branch, you will have really true coverage of the ostium of the side branch. In all other cases, you can imagine that you were covering with T, inverted T. There are a lot of even T protrusion. You can imagine that you are covering the side branch ostium. In peak hearts and in bench tests works very well, but in living human, the situation is different. And if you make some OCT or IVUS in those cases, in some cases you can remain highly disappointed from what you will see and what you were thinking that you see. Regarding the crush techniques, this is an overview from 2021. There are 6 types of crush techniques, and you can double this number by inverted techniques. And in 2020, there was a meta-analysis that was the first really big meta-analysis in which I have a humble participation, comparing different techniques of bifurcation stenting. And practically that was the manuscript which first placed for the first time, I repeat, in 2020, placed for the first time decay crush as a leading technique for bifurcation stenting. And in this meta-analysis, which is the intention of this meta-analysis, because we discussed this with Carlos Collet, he was here in 2019, and we discussed that he wanted to perform a meta-analysis from patient-level data. But the problem was that we can't obtain the patient-level data from decay crush studies. Xiaoliang Chen just refused to give us the data. I'm pro decay crush, but just I have to be honest about some of the history because I participated in some of this history personally. So we then decided with Carlos, he decided that he had to finish this meta-analysis because that was almost 2-year effort. And finally, it was published in JACC, and practically from this meta-analysis started the rise of decay crush as a primary technique according to the evidence-based medicine. So the decay crush was superior regarding the target lesion revascularization with a strong trend in reduction of the cardiac death and myocardial infarction, where the decay crush was clearly superior. That was the lesions with the complex bifurcations. And at that time, the complex bifurcation, and that was probably the strongest message from this meta-analysis, that the complex bifurcation means side branch lesion length more than 10 millimeters. And we here should keep in mind the data from definition trial, and probably this is one of the most prominent and most the largest achievement from Xiaoliang Chen, that I think personally that this classification about the complex, what is the complex bifurcation, should be kept in mind of every bifurcation interventionalist, just to orient ourselves when we should start thinking about two-stent techniques, not only about the decay crush. And every complex bifurcation probably deserves second stent. These are the initial procedure of decay crush. You can see here we have only 9 steps, not 11 like Nikki mentioned. Then in 2020, there was a white paper from the EBC about how you should perform decay crush. The technique was modified, and it was added this step of pot crushing the side branch stent, and then to recross, not just like in previous algorithm, just crushing with the balloon sized according to the distal reference vessel diameter. That was a step further, that you should crush with the proximally sized balloon, and then after recrossing, first kissing, stenting, the stent sizing across according to the distal main branch reference diameter, second pot, kiss, then third pot. And that was the final algorithm. In 2020, Francesco Lavara, who lives in China, and works in China for many, many years, proposed modification of the DK crush with optimization of the stent ostium. Francesco is one of the people who involved the largest number of patients out of the Nanjing hospital in the ODK crush studies. So he demonstrated that proximal optimization of the side branch stent after implantation ensures better results and easier crossing. And this is from the 16 bifurcation crop statement with this step implemented here with the proximal optimization, with the proximal POT crush, and with the different sizing and recommendations, and the steps now are maybe 12. So Nicky was very optimistic in his presentation. In November, in Asia, in November 2025, Xiaoliang Chen made a meta-analysis of his own studies. These are from the 4 of all DK crush studies, and inclusion criteria for inclusion in this analysis was that the mean side branch lesion length should be more than 10 millimeters in the study. So the patient only with the side branch lesion length more than 10 millimeters from the DK crush studies were included in this meta-analysis published 3 months ago, and there was a clear superiority of DK crush over the two-stent group, over a provisional stenting group. And to be honest, I was looking very carefully across the data, and the only thing which really deserves to be concentrated is that practically the rate of spontaneous myocardial infarction, because it was amazing for me that periprocedural myocardial infarction in DK crush was less than the periprocedural myocardial infarction in provisional group, but in the long term, here the follow-up is up to 6 years. The median follow-up for this patient cohort is 6 years. And now the rate of spontaneous myocardial infarction was practically 2 times less in DK crush group in comparison with provisional T-stenting group. And I think that this data deserves a lot of attention, discussion. This is my proposal for if just maybe on the next TBC just to discuss this, because this is the only parameter which could not be influenced from the operator. The spontaneous influenced in any way, maybe. So the target lesion failure was clearly superior because on the side of the DK crush. And again, this meta-analysis demonstrated the advantage of DK crush was concentrated only for the really true complex bifurcations with the long lesions on the side branches. So in conclusion, DK crush is the best studied technique. At least there is a maximum information which we have for any technique. It was superiorly concentrated, this superiority actually is concentrated mainly for the complex bifurcation stenosis. Keep in mind that probably this is really good technique for complex bifurcations, and experience matter. You should be familiar with all the steps and all the troubleshooting to resolve the problem which can occur in any step during the performance of DK crush. As I shared yesterday, in my life I performed only 3 DK crushes up to now, and I tried to find one of these 3 procedures performed for me during the years, and I can't unfortunately find even one. This is why I don't place any case for demonstration, but the data are as it is, and as I said, the experience matters. Thank you.
He is completely right. I fully agree. If we have a really complex bifurcation, we should do our two-stent technique that we are familiar with. Otherwise, we can have big troubles.
That means that nobody has done three complex bifurcations.
Nobody. I made a lot of complex bifurcations every week, but I don't use this technique. To be honest, what I'm doing is what somebody can name mini decay crash or nano decay crash or so on, which in my view, in my eyes, is properly performed stenting.
So I have some comments. I know also very well Chogyam Chen.
We have to extend.
I was in
the
this
session.
meeting. I was working in his cat lab and several years. And what I saw there is that I told you this afternoon. For them, a provisional stenting is a pot in only 25% of patients. So this is not a good comparison. Not a good comparison. Not a fair comparison, yeah. So, and another point, which is a TLF. The TLF is always in favor of decay crush instead of provisional. Even in decay crush 5, which is exclusively left main, if you use this, if you look at this, there is no difference in mortality. So, in a bifurcation with a distal LED with the third diagonal, we can understand that the TLF can be different. But in the left main, if the TLF is different, it should have mortality. There is no mortality, no difference in mortality. So I think I cannot tell Xiaoyan Shen that he is not doing. He was not proposed in all these randomized trials to have strict rules to follow, to do provisional stenting. On the contrary, especially when it is in the hand of Xiaoyan Shen, the description of decay crush by Xiaoyan Shen and the modification, some of them were coming from me, some of them were coming from me, is following him. He is following strictly his protocol. And I'm not surprised to see the result he has, Xiaoyan Shen. But in another paper, so is among the first meta-analysis, Dr. Lin, L-I-N. Look at L-I-N bifurcation. It's a long time ago. You will find a trial, read the paper. Because in this paper, they have QCA, and the QCA of the diagonal, the diameter of the diagonal is 4 millimeters in mean. Is it serious? Or they are strong people, big people with big diagonals? No. So, okay. And I'm doing, of course, I've never said, but they have much worse lesion that we have in Europe.
Yes.
I said him in front of him. You are. So we need, in this situation, we need to treat the side branch with a stent. I think my record was we had for a time I don't see is still there a 60 millimeter stent. It still exists?
Yes.
So I put several times a 60 millimeter stent in a circumflex as a provisional. I mean, after crossover stenting. So this is not conducted well. I don't say he's doing. When I ask him why 24%, how can it answer something 24% of pot? Of course, he knows pot.
Yes, and
And we will wait for EBC main. Of course, the lesions were less complex, but we will see a trend in mortality at 3 years, a big difference in target lesion failure, which is, okay, P002, I think. So wait to 1 year now.
the only concern, as I said, is the rate of spontaneous myocardial infarction, which is in favor of decay crash, which for me, and it is some, I don't know how to interpret, but
No, I don't understand. Because I have seen here in case session in Anjing, not this year, but last year, I have seen several perforations, even rupture. By, I remember a lady, I don't know if the lady was doing the case, but she presented the case. You know, this is, oversizing a maximum of the vessel. I'm
yes,
not sure that
this is because they perform ultimate trial, which is leading us how to size the stents, but I'm not sure that they are following their own rules.
yeah,
Because
so-
the ultimate trials and the ultimate criteria came from this cut lab from the Xiaoliang Chen, by the way.
I think the practice of sending to a paper before the trial, sending a paper showing the details of treatment in each group, I think this is fair, because from the beginning we will know that the two groups are equivalent. And if they don't do that, then for example, Illumin 4. Illumin 4 they declare what will be the primary endpoint. But it has been published now, and published at the paper, the so-called primary endpoint is not the primary endpoint. Very, very curious, no? So I think to have a good trial, you have to define what you are comparing. And this is done in serious paper.
But we shift the focus probably in another direction, comparing a decay crash with provisional. And first of all, we should say that provisional is the strategy. And it can always move to a second stand. And there is, for sure, some complex bifurcation that need 2 stents. The idea is whether the decay crash is the ultimate technique, because we know and we have a very good result with another techniques, which I would say are much more flexible. Because if you go, just imagine how many of us have done for the last month or 3 months a 2-stent technique bifurcation.
When I was working, was probably 2 a week. No, one a week for systematic double stenting.
Yeah.
Because provisional, of course, but 1 a week.
So,
But many people are doing 50 cases in US, 50 cases of PCI. And I cannot imagine how they can use a decay crash, which is a complex lesion, that they will do 2 times a year.
Yes. I mean, if you are doing 50 cases per year, you should not do a bifurcation. I mean,
Yeah.
that's another
If you
point.
do 50 cases
I have
per
a
year,
very last thing about spontaneous MI. Is it the difference we observed in the first day?
no, this is during the first 6 years.
So the change, because they are nearly parallel, what you showed. The
Yes,
difference was very small.
but for myocardial
So
infarction,
if the difference was this very small difference, is only related to spontaneous MI? I think it's related because it began probably a few days after the treatment, leaving a dissection untreated in the side branch. This is my opinion, because they have done 40% predilation in the side branch.
yes, something like that.
Before
the
putting the
predilatation,
crossover stent?
yes, that
This
was
is the way
also
they do
surprising.
provisional.
Yes.
This is not the way we do provisional.
Okay.
So, okay, but nevertheless, Xiaoliang Chen is a great operator, I have to say that. So we have A comment there.
Имаме ли връзка с доктор Ференц?
It's not a comment, actually, it's a confession. When the first time I saw Shaolin Chen on PCR doing the DK crash, and I came back to Štip in Macedonia, and it was year of two-stent strategy of all bifurcation lesion. And we did it, one intervention was lasting for 1 hour, 45 minutes, 2 hours. And we start working hard, and we achieve to do DK crash with all steps, 11, 12 steps, for 45 minutes. And we were very, very happy. We did around 50 cases in that, let's say, 18 months, until we saw the first recoro after 8 months, 1 year, that the side branch was pinching. And suddenly we were extremely happy that we were actually feeling like gods in the cath lab. We were doing all the vessel with the 2 stents and finishing everything. And suddenly we dropped down, and in the last 6 years we are doing provisional, sadly, provisional stentings only. And this is our confession for our cath lab that we did it. We rise it, we run it for the 2-stent strategy immediately. But now, I think in the last 4 years, it's only provisional stenting. This is our confession that we were so happy that we can finish, as we spoke on the dinner, we feel more comfortable when we put the side branch stent at the moment. But on the long term, the outcomes are, as you said.
And among the TLF, I said also already in afternoon, to pinch, when you would do a systematic angio, which is occurred in many trials, systematic angio at 1 year. Normally the angio was scheduled at 13 months, not 1 month after the 1 year endpoint. But many of the angio were done before the 12 months. And they found this pinching of the circumflex, they put a stent. This is TLF.
Let's proceed because Mirek Ferenc is waiting on Zoom.
Yeah. So we move to?
We move to Mirek. Hello.
Mirek. Marek. I said Marek.
Hi, very good evening, dear friends. Can you see the slide?
Yes.
Yeah.
That's fine. Yeah, it was very interesting discussion. I fully agree with you. What I recognize now for many years, we go definitely down from systematic double stenting. For sure. There was a double stenting rate of around 20%. And nowadays, if I just follow up for last 2 years, except our BBK3 trial, we go now something of around maximum 10% of bifurcation treatment is associated with double stenting. So we definitely try to avoid side branch stenting, particularly if we go from left main to LAD. I try, if only possible, I try to avoid circ LCX stenting, because we know it looks very nice in acute setting, but during follow-up we have more and more difficulties. We are located in very country area in Bad Kreuznach, close to Freiburg, very close to Alsace in France, and very close to Switzerland. This is our main building here. If you see this gray building, if you go inside, it looks very nice. So we have very nice infrastructure for our patients. So this is outpatient area, this is coronary heart disease area, this is TAVR clip area, and this is electrophysiology department. So what we do now definitely more complex PCIs. So we have the number altogether, number is going down, but the complexity is increasing dramatically. So this is what we observe. We need much more to use rotablator or orbital atherectomy or shockwave. This number is exploding at the moment. And of course, we have many left main PCIs. And what we do now, we perform now more and more FFR-guided PCI. So this is now nearly 28% at the moment. And of course, we go ahead with Impella. You see what I'm doing if I'm going to treat complex lesions. I'm starting now with 1 or 2, 3 frames per second for fluoro. This is particularly for younger doctors a very important topic to try to avoid high dose of radiation. And we know, of course, you have 20% of bifurcation, that's clear. Left main PCI around 3 to 5%, in selected centers even more. We have something between 5 to 10%. And you have to be skilled in bifurcation lesions, because if you just follow the ARTS or syntax study, you see there is at least one bifurcation which must be treated something between 50 to 70%. So bigger centers, they need to be skilled in different bifurcation techniques. And side branch protection, the first step, of course, if you have side branch diameter larger than 2.0 millimeters, or if you have maybe below 2 millimeters, but if you have very long diagonal or marginal branch, that means the supply area will be around 15% of myocardium. So that's why protect such side branches. Sometimes it's very difficult to wire side branch, even if you just want to treat patients with provisional approach. So what you need is different technical approaches for neck. Sometimes sporadically, nowadays we go with angulated microcatheteris. How often do I need this approach for side branch? I personally need this 1-2 times per month. So it's really very helpful to have this angulated supercross microcatheter. Or you go with Sasuke, like this example with double lumen microcatheters. Side branch, systematic side branch pre-dilatation is of course not needed. We have a study from Spain, from Manuel Pan, to see follow-up after 2 years. There was no significant benefit for systematic side branch pre-dilatation. And how often do we have dissection? If we pre-dilate a side branch, it is around 17%. So usually because some people say, okay, if we pre-dilate side branch, then we have immediately to put stent. It's not true, and there is still more than 80%. There is no need for side branch stenting. And even data from Korea, they could show us even there's we should try to avoid to pre-dilate side branch. So we know mostly carina is free of plaques. It's carina shifting, which is usually the case. So pre-dilatation is mostly not necessary. So we do this only in special anatomy, particularly if we have side branch subtotal lesion, if we have severe calcification in the origin of side branch, or if the side branch's lesion is longer. And of course, whatever we discuss in bifurcation, this pot maneuver is extremely important to achieve here optimal stent deployment in proximal segment. Then it's much easier to recross to the side branch. And we have clear data showing that systematic stenting is not beneficial over provisional. This was Nordic 1 study. We published short time later BBK1 study. Again, if you just perform very complex procedure with double stenting, after 9 months by angio, there is no benefit. And we have data from BBC 1 study show it that even if you go with systematic double stenting, you have more troubles, particularly because you have peri-interventional myocardial infarction. And this data is, I think, very important to show, even with the first stent, first DS stents, we could have a sign after few years. There was even larger or higher mortality if we perform double stenting. So this is some sign. We should be very careful with systematic double stenting. And what is, of course, very simple and very easy to do is modified TAP. But finally, if you ask me after many years of experience, it's not really very simple. It looks simple, but you still have to take attention not to let a gap, because if you have a gap, then you have to modify this, or if you have too large protrusion, that's still an issue. If you go with culotte or double kissing, this is for sure mostly clear. You cover the ostium of the side branch mostly perfectly, but in TAP, that's some issue. Of course, there is different anatomy for different treatment strategy. If you have very big angulation, this will be difficult to do culotte or decay crush, so this will be something for TAP. If you have long, very small angulation, very large side branch, this will be suitable for culotte. And if you have some anatomy, if you have side branch, if you have diameter difference more than 1 millimeter between main branch and side branch and small angle here, this will be mostly contraindication for culotte. TAP will be very difficult because of long neocarina, and this will be something for decay crush. And Dobrin has mentioned very, very nicely, yes, there is sometimes very difficult anatomy if you don't have clear message where to stop here with a stent in the side branch ostium, then maybe think about, okay, decay crush, culotte will be maybe in such options better. And we have also data, randomized data from BPK2 trial, TAP versus classic culotte with Olimus stents, and you see there was a significant benefit for culotte because we could cover the ostium of side branches more sufficiently. And this angiographic restenosis was associated even to better long-term follow-up during follow-up. So you see, there is in the side branch, there is a benefit of culotte, 6.5 versus 16 after TAP. And there is just showing after 1 year, there is even some trend to better clinical data after culotte stenting. So the T-stenting or culotte, T-stenting or nowadays T and protrusion, it's not so easy. Usually you are ready with single stenting, kissing pot, but if there is dissection, if there is residual stenosis more than 90%, so then you can go with one more stent, and this is now demonstrated how you should stent the side branch. If you go with a stent deployment in this position, you could have here some gap. If you implant the stent in the side branch in this position, you will have a very large protrusion. So this will be bad culotte, bad TAP stenting. So the optimum position is protrusion of around 0.5 millimeter into the main branch. And then you can implant the stent, do post-dilatation pot, kissing, final pot, and then you can practically make from two stents one such nice device. We have now data which support very supportive for TAP. We have data from ABC main study in the left main. So you saw only in 20% there was need from provisional to go to double stenting. So in 80% of such patients. You can treat patients very nicely with one stent. This is the same number like in BBK1 study. We had a 20% crossover. And if you have crossover, then you have much more problems. So then the target lesion revascularization is increasing over 30%. So this is our own analysis from BBK1 study. And you see just example, this was a randomized patient to one stent for this left main lesion, but finally stenting from left main to to LAD, pod, key stent pod, and we could manage this case by one stent, using one stent very nicely. And even after 6 months, you see the result was still very, very good for this patient. And this is approach which I definitely try to implement in our daily routine. Try to avoid circ-stenting. If you see this CTO with this bifurcation, this is of course extremely difficult anatomy, so you can just go here with double stenting. In this case, it was I performed a dickey crush. It was no option to go here by a provisional approach. Yeah, we have now more and more data supportive the approach with drug-coated balloons. Solution study was non-inferior for solution drug-coated balloon compared to stent, to modern stents. So the studies are ongoing in bifurcation setting, and we see there is still very, very low target of MACE rate after use of drug-coated balloons in bifurcations. And finally, Eve knows this animation. We have ABC device from a US colleague, and this will be maybe an option to go more and more in this provisional tap approach. So this is a stent which is going over 2 wires, and you put the balloon from the side branch back. You have 2 markers, and then you go forward with a stent. So the balloon from the side branch is going into the side branch, and you can implant the main branch, and with side branch balloon, then the main branch balloon, and you have a very nice ostium modification to the side branch. So if just needed, if there will be need to go with one more stent, the tap will be extremely easy to approach. And nowadays there will be option to do this to cover this balloon with a drug-coated with paclitaxel or sirolimus. So this will be a very, very elegant way to treat bifurcation, drug-coated balloon and stent for the main branch. So, dear colleagues, provisional side branch stenting is still gold standard, and more in the current approach, more popular than even a few years back. So you can go still with this approach with TAP or dickey-colloid forward. We are waiting now for the data for BBK3 trial. This data will be presented probably this year during TCT. It is comparison dickey-colloid versus dickey crush in non-left main bifurcation lesions. Very interesting study with just synergy stents. And as I mentioned, yeah, drug-coated balloons will be very, very good option, even to reduce the number of stents in the side branches. Thank you so much.
Very good presentation, Marek. So,
yeah, thank you.
Any comment? Is it Marek or Mirek?
Yeah, both. Both is okay.
Yeah.
If you're Polish, it's Mirek.
Yeah.
Okay.
In Germany, they call me Marek.
Okay. Just a comment regarding the dedicated stents. Unfortunately, during the years, what I learned from bench testing and patients and so on, we are going in spiral and going again with these two balloons into the side branch. There are only two main technical problems for implantation of this type of stents. And the first one is the length of the stent, because you cannot produce universally size for every bifurcation. And the second problem is the twisting of the balloons or wires. And
Twisting is finished with this.
and yes, and if you have any tortuosity into the road of, on the level of the subclavian or into femoral, iliac, and so on, any tortuosity anywhere during the road of the guiding or inside the coronary, you cannot redirect the system to place it in the proper situation. And the first was frontier stent, if you remember, from Gaiden.
Oh, yes,
Then
yes, but
became from the Boston stent. Then there was several versions of BIOS which never appeared on the market before that. And we
the Cordis was a Cordis, was
yes.
a Bard, was so many. One from Italy, I did in PCR
Yes, no, in
a live case, and I twisted.
Yes,
I have to use a snare.
Exactly.
But what Marek has shown, the stent that he showed at the end, is FDA accepted, and he is trying to find centers to make trials. He have some small trials, but and this stent is completely covered, so you can go safely even in something very sinuous. So this is, for me, this is the last chance of a dedicated stent. We have tested so many. This one, for me, much better than the previous one. So we will see. We will see.
Yeah, if I fully agree with you, this is a really modified technical approach. So we probably will have much less twisting than in other older devices like Dobrin just mentioned. I think the way will be to use this device probably in proximal bifurcations, maybe not in very distal tortuous vessels, but for left main, for proximal LAD, this will be probably very suitable device. We will see. We have to wait for a bigger study, that's for sure. And don't forget, dear colleagues, we have nowadays much more we know how important is lesion preparation. We have now better devices for that. We have Shockwave, which I personally use a lot in calcified bifurcation lesions. So we can prepare the lesion of the side branch much better, more efficient. And then that's probably the issue why we don't need in every case second stent.
Thank you. Any question? No. Thank you. Thank you, Marek. I hope to see you soon.
See you
Bye-bye.
tomorrow morning.
Tomorrow morning.
Yeah, bye-bye. Thank you so much.
So now Dr. Nair will come to speak about culotte and other bifurcation technique in 2026. He's working a lot, huh? You are working a lot.
I'm limping a lot. Hello again. So this is very difficult for me to do because all this has been already spoken about. People have talked about the culotte technique. People have talked about various bifurcation techniques. So I may be repeating a lot, but remember, if you hear it often, you're likely to remember more. Also, I have to be somewhat creative to see if I can still hold your interest. It's late in the evening, and I'm going to repeat a lot. So to go back to some of our thinking about bifurcations, the first thing to decide is which bifurcation should you treat with the single provisional stent, and you've heard this often, and which bifurcations should you treat with two stents. So all lesions, all bifurcation lesions should be divided as complex and simple, and we've talked about criteria to decide complex and simple. And by and large, complex lesion, you will go upfront two-stent strategy, and you can choose your own stents. And simple bifurcation lesions you can treat with provisional stenting. Of course, like it's seen in this particular slide, sometimes you start with provisional stenting, where all your intentions are to put one stent, but you may start to lose a side branch, and if it's an important side branch, then you have to bail yourself out with another stenting. So those are those two situations where you need two stents, complex lesion and simple lesions that fail. What this really means that anybody that goes into the business to do bifurcation stents or complex intervention should be very familiar with all the techniques, because even though you might say, well, a majority of the time I'm going to do single stent, but unfortunately maybe it's 3 times a year, Dobrin has to do, DK crush, but he needs to know all the steps of DK crush, even though he's doing it 3 times a year. So anybody that does such cases should be familiar with all of the techniques. One is so that you can do it, and second, to decide when you don't want to do it. So this is very important. Since the main topic is Coulard, I put this slide in to show you all the various steps. It's too much to go through all the various steps of Coulard, but what I circled was what has already been mentioned a couple of times, including the last speakers spoke about the angulation, and the Coulard stent is very good for shallow angles because you have very good carinal coverage. It's also good, no matter in what situation you use, it's also good. The principle here, because this has been spoken about already, is to remember the various steps and where you can possibly go wrong. And the one place that a lot of beginners go wrong is because they forget to pull the stent out of the stent that's already been behind the stent that's already been deployed, and you inadvertently try to put a stent down the trapped vessel. Has that happened? Yes, it has happened. And sometimes that stent is very forgiving, and now suddenly you have a stent behind the other stent. So that's not good. So to remember which wire is where, and you have to keep the main wire separate from the side wire so you don't put the stent on the wrong wire. So these things are very important, especially if you're working with trainees and you're using the same wire, then you may get confused as to which wire is out. In that situation, it is best to put both the wires out and then rewire. It's a painful job, but you don't want to make the other mistake. The second mistake is that once you've gone through all these stents, is to pull the side branch wire out and try to rewire it, and you end up behind the previous stent. And there are ways to rescue that, but if you do go behind a stent, then that is not very good. One of the ways to avoid that is to do the part with a trapped wire of the proximal stent, because the main branch is bigger, and then the gap between the stent and the vessel wall is not that big that you can go into the lumen of the stent rather than ending behind the main branch stent that you put first. So part is one good way to avoid, and second is, if you're not sure, is to start all over again. Because once you run into the trouble of going through the stent struts or behind the stent strut and you start to put balloons and wire, then it's a big disaster, and there are ways to get out of it. But instead of spending 45 minutes, you will spend 2 hours trying to save that. Why is the Coulard technique good? It's because by and large, if you cross the main vessel appropriately, that is, it's not too proximal, then the carina is usually maintained. Why is the carina, maintaining the carina important? Because it changes the flow characteristics, and we think if you change the flow characteristics, that the in-stent thrombosis rates as well as the long-term restenosis rate are likely to be low. So preservation of the carina is pretty well done with the Coulott technique, and this is a bench model. Now, this has already been mentioned because I'm going beyond Coulott. This is the stepwise approach to a T technique that's already been mentioned. And this is a good technique for wide angles. If it's a 90-degree angle, it works very well. If it's less than 70 or so, then there is a certain portion of the side branch which is not going to be covered, so that there will be lesion miss, and that would be a nidus for in-stent restenosis. So one needs to study the angle, and to know the angle, you have to look at the vessel in multiple angles, because in one angle it may appear to be right angle, another angle it may appear acute. So it's good for right angles. Again, if you have right angles, the Coulott and the decay crush has already been mentioned, becomes much more difficult because it is hard to cross through a stent stud, especially in the decay crush, into a right angle. Very, very difficult. And when crossing the stent with another stent, no matter how you've done part, side branch, pre-dilatation, crossing the side branch, opening of the stent stud, etc., can be very difficult. And when you start to push, the stent gets distorted. Now, you may not see it angiographically, but the stent will get distorted if you work very hard with that angle. So these things have to be kept in mind. Now, TN protrusion has already been mentioned. This offers much better coverage of the side branch osteum, so that if the angle is not exactly a T, then if you have the T stent, the side branch stent protrude into the stent, then you will have appropriate osteal coverage of the side branch. So rather than doing a classic T, it is best to overdo the stent a little bit and pull it back into the main vessel. Now, with either of these two techniques, one may miss and pull too vigorously, and the side branch stent will be now in the main branch. And Mehreg just mentioned what happens if the stent is protruding too much. Now you're not doing a nano or a decay or a Coulott. You're in no man's land. That's not good. And one of the ways that I have found, and I have told the fellows this, is to do what is called straddling. That is, you put a balloon in the main vessel along with the stent that is put in the side branch. You can partially inflate the balloon in the main vessel, pull the stent so that it fits snug to the partially inflated balloon. So you are sure that you're not in the main vessel completely, but you have also covered the ostium. So this technique, it's been discussed. I tend to do that often. The other thing is, if you make a mistake and somebody pulls the side branch a lot, then you can use the main branch balloon to actually crush, and you can get a nano crush at that point. So we haven't lost anything by putting the T stent much into the main vessel. The problem, if you don't have that other balloon there, is that if you're associate, you never make a problem. It's usually the associate that creates a problem, right? We are never at fault. It's the other person creates a fault. If they pull it too generously and that side branch stent is in the main vessel, then recrossing the main branch with the wire or with the balloon becomes extraordinarily difficult. And again, you have mangled metal at that junction. And again, that's not a good scenario. So these are electronic images that the placement of the side branch with T or TN protrusion is very, very important, so that you don't want to have the miss, and you don't want it to be too much, because then you have mangled stent or too much metal at that junction. So being very meticulous with your technique is very, very important. It's always important in any PCI, but it becomes even more important when you start to do complex intervention with two stents at a bifurcation. Just a slide to mention to show that where you cross that, that main vessel. You want to not cross it proximally, you do want to cross it distally, so that as much as possible. It is very difficult to really see where the wire is going, but you don't want to be in the wrong place when you cross this. This we have discussed already. If you have to do provisional stenting, there are very many ways to do it, but you always have to recross. This is a classic crush technique, which was, we used it before we got the DK crush. And it's very similar to the DK crush, except you don't have the double kiss as the first step. Many people still do it, but I don't know if this classic crush has been compared to all the other stent techniques. As you know, in all of these studies, it's very difficult to study one technique versus another, and so DK crush was studied with the Coulard because Coulard apparently had the best outcome with the bifurcation stenting, so DK crush was compared against that. And we feel that these other techniques are perhaps not as good to reduce the MACE. So it can be done. This is translated into nano crush, DK crush. The techniques are the same, but how many steps you do with DK crush is what is important. Now, one of the problems with the crush technique is the amount of metal that is left in the main vessel. As you can imagine, there's going to be 3-4 layers of metal, and is more metal, more polymer, more drug, is that really very good? Does that change the physiology of the downstream vessel? We don't know all this. But by and large, we think that less is more. So it makes sense not to have a lot of the side branch stent in the main vessel when you do DK crush or any kind of crush technique, to keep the amount of double layer of metal low as much as possible. Less is more. So you want to keep that overlap short. So you have to be very careful on fluoroscopy, matching the stent and the markers to see exactly where you are placing the side branch stent. This is an OCT image of a properly done double stent technique, and as you can see in C, you have a very nice carina well covered with stent. The importance of this is not how good the pictures show that the stents are, but to show the importance of imaging in these situations, how imaging will help considerably. If a stent strut, sometimes the side branch appears to be pinched, but it is an optical illusion because there is a stent strut that sticks exactly on the ostium, and this depends very much on where you crossed it, and you cannot predict where you cross it. So if you see that the side branch is pinched and your imaging shows that there is a stent strut there, then you can recross it, do another kissing stent, and you'll realize that kissing balloon, and then you'll realize that that ostial narrowing has now disappeared because you've corrected the cause of this apparent pinching of the side branch. I will not show this again, but the crush technique is, any kind of crush technique is more or less done the same way. It's appropriate for shallow angles. There is a reverse crush, so that if you want to put a stent in a vessel that's the side branch that is occluded from dissection or whatever, you can also rescue that branch without a tap or without a TN protrusion, and you can do a reverse internal crush. So these are all various techniques. You can do modifications of the classic crush. V stenting is very rarely done and can be done for a bifurcation lesion that does not involve the main vessel. So very, very rare, but you have to be careful that you don't pull this back out into the main vessel, and then you'll have this technique, which should really not be done. It should be abandoned. And this is a kissing technique, which when I began way back when, some people used to do, because, especially for the left main, because it was very easy to wire, balloon, stent, and angiography. It looks very good. but 6 months, 1 year down the line, you have a completely restenotic vessel. So in very elderly folks recovering from cancer or dying of cancer or a patient in cardiogenic shock, when you want to get in and get out very quickly, this is a very easy procedure to do. Very rarely done. I don't think I have done any at all. And we talked about bifurcation stents. Since we're talking about various kinds of stents, I brought this one up. And that is all I have to talk to you about. A lot of it is repetition. I try to be creative and add something more that was not already discussed. If I repeated everything that was discussed, I apologize, but hopefully you'll remember some of these things. So, in conclusion, 2 stent strategy used for complex lesion, I've already repeated, or a bailout option when the side branch is getting occluded. There are different ways of doing it. They have various niches, like I said, wide angle, shallow angle, etc., etc. And there are some advantages and disadvantages to all the technique. And I mentioned in one slide, it's very important to have intravascular imaging at your fingertips. So in case of doubt, in case of not being sure, you can always image whatever you've done and correct your issues if necessary. And by and large, the long-term results with imaging, especially when you have lots to lose, left main stenting, is very, very important. Thank you for your attention.
Any question? I would say burning question because it's getting late. No, thank you very much, Ravi. So the last speaker will be Gianluca Rigatelli. Will be transmitted? Recorded. This is recorded, yeah. So this one.
Good morning to everybody. A warm ciao from Verona, Italy, from me, Jackie. I'm here 10 days after my hip surgery, so I cannot be present in Sofia, but I miss you all, and in particular Dobrin and Valerie. But I'm pleased to deliver my speech in pre-recorder fashion. My speech is focused on stent technique and left main, bench test, flow analysis, and clinical results. Actually, honestly, I have to say that very few left main stent techniques have both bench test and CFD analysis, very few. And the majority of whom have a CFD study has really very little clinical data. For example, nanoculotte or nano-DK crash, just to mention some of the most modern customized techniques. Non-inverted D, which is my own technique, is the only technique conceived theoretically, tested on bench and CFD, and applied clinically to have a robust clinical data throughout more than 10 years of application. For that reason, my speech will focus for the most on non-inverted D. Just some facts about our home technique. From the conceiving in 2012, we go through bench and CFD assessment, and then we applied the technique in left main and long left main patient, but nevertheless, we continued to test the technique in vivo also by computational fluid dynamic, and through more than 10 years of application, you can appreciate here that we went throughout extensive publication of the both CFD study and clinical outcome evaluation. And the last paper is it was published about 15 days ago, and we compared in a match propensity fashion non-invariant versus provisional in full complex bifurcation left main. It is you can find it in CCI 2026. Well, just a brief introduction to the technique. This slide I show a lot of times. It shows the main steps that are very few compared to the other technique. Wiring both branches, putting the stent, placing the stent in the side branch with a very, very minimal protrusion of the shoulder of the first crown, not all the first crown, but just the one, the shoulder prospectant to the carena, just to anchor the stent, a crush with a balloon into the left main, siding 1-to-1 to the left main, then stent of the main vessel, pot, rewiring, snuggle kissing, final part. And you can see in the last panel that the coverage of the side branch is partially by the side branch stent itself and partially from the protruding struts of the left main stent. Yeah, this explains you why the placement of the stent is not too much much cumbersome, and the technique is very, and why the technique is pretty fast to be done. If you put together all the techniques we use usually, you can see that the crossover, obviously the key point is a pot, the culotte, the key point is a final kissing. In the mini crush and decay crush, the key points are the double kissing, and for the non-invariant, the key point is a double part. So it's not really a crushing technique. And obviously the key point, another key point is that the side branch has a double mix of coverage from the main stent and from the side branch stent itself. But really, I have to admit that is not a crushing technique for itself. And for that reason, we changed the name from nano crush, which was the name in the early stage of the technique, to a non-inverted T following the suggestion of ABC, just to be clear, that make clear that the stent itself, the stent technique itself is not. I consider the stent technique in my mind. Then I went to the facility of Biotronic and we applied the stent on bench. And with a micro CT, I look to the carena, and you can see here that there is no real double layer, unless one portion, a small portion of the first crown of the side branch stent. And then we applied computational fluid dynamic study, and you can see here that from the internal view of the vessel, compared to provisional, the non-invariant has got a very rheological profile. Red it makes turbulence and high shear stress forces. Green, blue is low shear stress forces. If you compare both, there is not much difference. So that study ensured me that the technique has a very physiological profile compared to provisional. stent. And then we applied the technique to human, and but we continue to assess the computational fluid dynamic in real patient, and this is a study that we published a couple of years ago, and we look to comparison versus provisional decay crash, and you can see again that here, riding worse, blue is better Gaussian stress force profile, and you can see here that the mean average Gaussian stress value are very good in non-invalidity, less good in decay crash and provisional when we study only the true complex left-mean bifurcation. And if you look to the resident time, that is the amount of time the blood flow recirculates and staying into the bifurcation areas, the comparison is again very in favor of non-invalidity compared to the crash and provisional standard. To assess the clinical outcomes, we publish extensively. This is a key, the first publication in International Journal of Cardiovascular Imaging with a 3 years outcome. This is our publication left main in cardiogenic shock and STEMI. And we suggest that the technique was faster, less expensive than Coulard in STEMI in shock patient. Then we look to the technique in STEMI patient, and again, we suggest that non-invalidity was more effective than Coulard and TAP in STEMI patient. And finally, we look also to gender-related differences and among different single or double main bifurcation stenting techniques, and we suggested that non-invalidity was better in females than Coulard or decay crash. If we look to the whole amount of patients treated in more than 10 years, we reach the number in up to the 2025 or 25 patients. Now we are around 600. The mean follow-up was very generous. TLF and TLR are less than are 6 and 3% respectively. Mortality, global mortality rate was 2.6%, no death occurring during the first year after the PCI. And if you go to look at the clinically driving angiographic follow-up, only the significant clinical restenosis was 3.3% located at L6 ostomy, and mostly due to incomplete expansion of the ostomy due to severe calcification. So we go to the last publication, appeared in the CCI in January 2026, 15 years ago. We compared, we performed a propensity match comparison of provisional versus and non-invalidity in complex bifurcation, complex defined by ABC and definition trials criteria. And you can see here that at 3 years, the cardiovascular mortality is much in favor of non-invalidity in all the class of the patient. Just a brief example, very complex bifurcation into views. Then here, throughout the steps, predilating bone branches, putting the stent in the side branch, first part, rewiring, snuggles, kissing, final part, and the final result in a very short period of time. In this 62 years all the years men with anstomy presentation. So if you compare clinically and also computationally the various, the different stent technique, we can appreciate that probably provisional has the best profile and also the best clinical. There is no doubt, but when you go through complex bifurcation lesion, non-inverted T is superior to top, culotte, and T-stenting, and in my opinion, also superior to decay crush because it's not a cumbersome technique, as involved much less number of steps compared to decay crush. So it can be used also by young operator or not so much trained operator. So in conclusion, non-invasive technique can be considered the only modern technique testing in bench and CFD before and during clinical application. The technique in left main showed improved long-term outcomes with low TF, low TLR, low mortality, and near 0% thrombosis. In left main provided easy and faster vascularization, low X-ray exposure, and low contrast dose compared to the other techniques, and appear attractive in emergency case, anstomy, and female gender. And in conclusion, non-invasive offers an alternative to other two stent techniques with a more favorable CFD profile in complex left main bifurcation. Thank you so much for your understanding, your patience, and your attention. I wish you a very successful DBC Congress, as usually, and thanks again for being involved, keeping me involved in this meeting. Ciao to everybody. See you the next year.
So this is typically difficult to have a discussion with him. So, and also this was published, and probably none of us have read the paper. This is the second.
It was published actually last week.
Yeah. So, but I think this is interesting as an alternative of, for example, decay crush for long side branch lesion. Can be an option. So, but this is coming from a single center, and as always, is better. It has to be confirmed by other centers, even if it's on a registry. If you are interested by this technique, you can do in your center, collect the data, and follow the patient. I think this is a way to perform, to push the science in this treatment. So, any comment? But difficult to discuss this now. So.
Yes, because Valery asked me that I'm not doing complex bifurcation, I'm using this technique. And we sent 9 patients from our lab to Gianluca, and with the follow-up, and we made a joint, tried to make a joint registry because it is very difficult to follow all the patients. As you know, we are collaborating for many years, and the problem with this CFD analysis is that it is very laborious. I mean, to obtain these beautiful pictures, you need 2 days' work just to have at the end all this analysis. And you can imagine if you want to perform analysis of 200 patients, how many, what powerful computers you need to just to do real proper analysis, because probably this is the future, to find a way to improve the techniques, to have a clear vision from the hemodynamic point of view, what
Yeah.
happens and how it happens.
I think for this, the discussion is open. We have one trial from one center, excepted you. And yeah, to confirm that the interest of this technique is we need more data. So, more data, you know. Provisional, we have thousands of cases.
Yeah.
This technique is
200.
500, 200? 500.
It is 525 at the moment.
Yeah, so I think this is the end of this busy afternoon. And now it's time to go for dinner. So.
Yes.
And of course, I hope that tomorrow we'll have the same assistance as today for a new, you have the case and maybe the complication. So this is normally a very good session.
Yes.
Thank you very,
This is
thank you very much and see you tomorrow.
See you. Thank you.